I'm going to talk about education today. My title is a little obscure, except for those of you who might have read The Hitchhiker's Guide to the Galaxy. But I wanted to highlight something that I think we miss sometimes about education. The old aphorism that frankly makes me nauseated now when I hear it about teaching people to fish. I think one of the things we miss is that what we're teaching or how we're teaching may not be appropriate. Either to particular cultural learning styles, as Dr. Weisner said earlier, or perhaps to circumstances that are inherent in that environment, such as Dr. Matlack alluded to a minute ago. And I think the problem is that when we try to teach if we try to teach things that are inappropriate or in an inappropriate fashion, it diminishes the sustainability of what we're doing. Of course, education is the ultimate capacity builder, I think. We're all here for capacity building. That's why we're all doing this work. And I think that not doing the education in the correct way decreases that ability to increase capacity and maintain sustainability. Now, sustainability is one of those words that you hear all the time. And if you subscribe to our friends at XKCD, one of my favorite comics, if we continue on the trajectory of increased use of the word sustainability by in the next 100 years, every sentence will consist solely of the word sustainable. But this is the problem that we're talking about. I know this is a busy slide. I'm sure you've all seen these diagrams before. This is basically maps of the world that have been reprocessed to reference population, global burden of disease, so on and so forth. As you can see, well, which one is it? It's the top right one there is the burden of disease. You can see that although Africa has 24% of the burden of disease, if you look at the bottom right there, it only has 3% of the global health workforce. It's estimated there's about a billion, that's a B, billion people in the world who do not have any access to any healthcare at all. And that is, of course, what we're talking about. That's why we're all here. It's something that I think we can all do something about. We're all trying. And I think events such as this help with that greatly. One of the problems is we're not even there, the countries that we're trying to help, the countries that we're working in, are not even replacing the people who are retiring and dying. This is a study that was done a year or two ago where they looked at the current growth rates versus the growth rates of the health workforce in 7 different African countries. The required growth rate to replace those who were dying and retiring and to keep pace with the population growth. You can see from that slide that not a single one of the countries that were surveyed is even coming close to meeting the required growth rate. Now, note 2 things, please. One, this is purely to keep up with the population growth rate. This was not to address the issue that I showed you in that first slide, that they are way, way behind on their workforce. The second thing to note is that 3 of those countries have a negative growth rate. So not only are they not keeping up with the retirees and the deceased, they're losing people. And I'll talk a little bit about that later on as far as where they're losing them and why they're losing them, perhaps what we can do about it. So we're talking about developing healthcare systems, we're talking about improving healthcare systems, and this is a little slide that I made myself, which is why it's really busy and makes no sense to anybody unless you have the same pathology that I have. The 3 main points about developing a healthcare system: quality, suitability, and availability. If you look at them in order, as I've put on the slide, quality comes from both the training and then the ability to assess that training. Are you providing adequate care? No. Why not? That needs some sort of assessment. If you look at the suitability, those educators and those providers need to come from that community. They need to be trained appropriately for the conditions and for the patients in that community, in that region. And they, again, have to be responsive to changing needs. By this I mean, for example, the epidemiologic transition that's going on in many parts of the low-resource world, where we're moving from an infectious disease-dominated problem to a non-communicable disease-dominated problem. And if you look at the the models that are in place in a lot of the low-resource world, including Sub-Saharan Africa, where I do most of my work, they're actually having a bit of difficulty with that. Part of the problem is that they're slow to come to terms with the fact that these things are changing, but they're also having a hard time convincing us that these things are changing. A lot of the mission work that Dr. Matlack referred to these are individuals who are still working under that assumption that the major killers are malaria and so forth. This is going to be probably the first year in history where more people are going to die from non-communicable diseases than from communicable diseases. And I don't know if the people who are engaged in these mission activities truly appreciate that. Moving on to the availability section, I talked earlier about these folks have to be locally educated and locally trained, but there has to also be employment opportunities for them. I'll talk a little bit more about that in a minute. But if there's nowhere for these guys to go, they're going to find a job. They're just like us. They want to work. They want to make some money, take care of their families. So they're going to go where the work is. And if you're not providing those jobs, they're going to leave. And then the last thing, of course, is that you need to increase the workforce. The slide a minute ago about the falling behind, they really need to increase the workforce. They need to replenish the workforce. And they need to have systems in place that enable that to be an ongoing resource and an ongoing prospect, an ongoing activity. All of these things together will hopefully feed into each other, as you can see from my cute little arrows, and feed each other and back each other up and enable this kind of thing to continue. So what are the problems? Well, the number one problem in any kind of, I'm a very linear thinker sometimes, and if you don't have a good primary and secondary education process, you haven't got the people, you don't have the manpower that you're then going to train to become healthcare providers. This is being approached in several different ways well, again, going to be mostly Africa, my examples. One of the ones that I thought was really interesting was the Africa Leadership Academy, which is based in South Africa. And their idea is they go all over the country, all over the continent rather, and they recruit what they consider to be the best and the brightest, and this is off their website when they say best and brightest. And they bring them to South Africa, and they, quote, prepare them for leadership. And that leadership is politics, it's business, it's administration, it's medicine. And when they do that, what they're doing is really preparing them for university, for college, for postgrad work, for further education. Obviously, these kids aren't going from secondary school to the government, but they're prepping them for elite institutions. And indeed, it works. 95% of these kids have received scholarships from elite institutions. When I say elite institutions, unfortunately, I'm mostly referring to those in Western Europe and the United States, although there's some very good ones in the continent of Africa and indeed in Asia. But most of these kids are going to Western Europe and the United States. And unfortunately, a significant number of them aren't coming back, which kind of defeats the whole purpose. I don't have a solution for that. Obviously, the fine people at the African Leadership Academy are probably working on that. But that is certainly one approach that is being undertaken. Another one is the medical school prep courses. A lot of medical schools in Sub-Saharan Africa are actually influencing and in some ways actually directly teaching in secondary schools. The idea is to prepare these kids for careers in medicine, for careers in medical school. And like in Western Europe, in Africa, med school is an undergraduate degree, so they can snag them early from secondary schools. The other approach, which ironically is the one they used in my medical school, which is the first year of medical school was really just to make sure everybody was up to speed, make sure everybody had the same basic biology, chemistry, math, etc., so that you could then proceed in your, quote, second year to actually learn medicine. And that's another approach that's being used in a lot of low-resource settings. One of the other major problems is there aren't enough institutions. Not enough med schools, not enough technical training schools, nursing schools, etc. As you can see from this graph, there has been an increase in the last 10, 20 years. But if you look carefully, you'll see that most of that increase has come from private institutions. Currently, in 2006, 22% of African students were enrolled in private institutions. And at the time, that was actually equal to the percentage of European students enrolled in private institutions. It is predicted that within the next 5 years or so, the number of private institutions in the continent of Africa will supersede, will be greater than the number of public institutions. Could be good, could be bad. There's a couple of different ways that these things are manifesting. One way is the locally owned, locally ran, locally financed private institution. For example, in Somalia, the 40 universities are all privately owned, all privately run, mostly Somalian. The other one is the franchise concept. Carnegie Mellon just opened a campus in Kigali in Rwanda, which is kind of an interesting construct because they somehow managed to talk the Rwandan government into footing the bill, and yet they're maintaining complete control over curriculum and admissions. Now, there's some question as to whether their government's going to allow that, given the recent crackdown on free speech in Rwanda. But there's certainly an interesting collaboration going on here. I'm not sure if there's something going on underground or if there's actually a very foresightful project underway here, but it'll be interesting to watch. One of the problems is that they're charging exactly the same as they charge here. The tuition is going to be over $37,000 a year, which is a lot of money if you're in Rwanda. However, the government has set up some systems for loans, and there's a lot of scholarships available. So the idea is that the Rwandan students will pay considerably less than the $37,000. And one of the things that they underlined repeatedly in their press was that for a Rwandan student to get a Carnegie Mellon education from a Carnegie Mellon campus in the United States would be considerably more than $37,000 by the time you have transportation, accommodation, et cetera, et cetera. One of the other solutions, and I know Dr. DeVries loves this idea, is teleeducation. If you don't have people and institutions in the places that you're concerned about, well, why don't we have them log in and see what we do? IBM are predicting that by the year 2016, that digital divide between the rich and the poor will have gone. The reason for this is largely the computer prices are dropping spectacularly. The internet-enabled mobile phone is becoming ubiquitous. And the other reason in the middle there is, I wrote global fiber optic cable, but what I really meant was the Soccer World Cup. To ensure that everyone got to watch the Soccer World Cup, you all watched it, right? The East African nations got together and they, mostly run by South Africa, they inserted a ton of fiber optic cable up and down the east coast of Africa so that the signal from Johannesburg, Cape Town, etc., was never interrupted. And so consequent to that, what's happened is that all the countries have tapped into that, and now they have huge internet accessibility in Africa. In fact, over the last 10 years, African internet use has increased 4,000%. Globally, that's about 480%, so they're tenfold greater. Of course, they were coming from behind, but still a pretty spectacular increase. The opportunity for teleeducation, I think, is huge. We're looking into it here at the Center for Global Surgery, not only for undergrads and medical schools and postgrads, but even so far as teaching surgical techniques remotely. I know that UNC and MIT have online courses that you can take, and by online I mean anywhere there's a computer, so not just somebody sitting in downtown Chapel Hill, but anywhere in the world that you have access to computer and internet. But as an anesthesiologist and as someone who works with surgeons, I think the opportunity to teach people how to do clinical cases, clinical procedures, is very exciting, and we're looking into that under Dr. DeVries's leadership. So this is one of the big hurdles, I think, faculty at universities and medical schools. The problems when you survey these folks, why are you leaving, why did you quit, why don't you want to be faculty? These are the reasons. And some of us who are in academics will recognize these as problems that we have too, and problems we struggle with, and problems we haven't come up with a solution for. So of all the surveys and all the papers and all the journal articles and blogs and posts I read about this, nobody actually had any good solutions other than give them more money, which is a similar approach to here, and as an academic, I would like more money. But I'm not sure that that's going to address all these issues in the long term. But obviously salaries, the ability for people to change careers and enhance their careers, the increased teaching loads, and here we are calling for more enrollment. We're calling for more students and more universities, and somehow the same number of faculty are going to have to do more work. And then, of course, there's the ever-present infrastructure, equipment, and support staff lack. So if anybody has suggestions, if you could write them down on a piece of paper and send them to me, I would love to publish them. So not only are you having a problem with faculty, but you're having a problem with graduates. Graduates leaving what they thought they were going to do, going elsewhere. This is a nice study from a few years ago. Sub-Saharan medical school graduates 5 years after graduation, where are they, what are they doing? And I kind of simplified it here. The original one had a lot more detail, and I didn't think we needed that. But if you look here, 28% of Sub-Saharan medical school graduates have emigrated within 5 years of graduation. They don't all leave Africa. 27% do. 22%. But 28% total leave the country in which they're trained. That's a huge drain. That's a lot of money invested, and then of course you don't have that person to take care of your citizens. The quote at the bottom was from a study a few years ago where they found that there were more Malawian doctors practicing in Manchester in England than there were in the whole of Malawi. And there's very good reasons for that. There's very limited post-grad education opportunities. So some studies show that in some countries there's less than 25%, there's not enough positions for more than 25% of the people who graduate. So you finish your medical school and what do? There's no residencies, there's no fellowships, there's nothing to do. So you leave, you go somewhere where there is the jobs. And then moreover, when you even finish your residency or your fellowship, there might not be a decent job in the country. And this was an interesting thing, and I know Dr. Krishna is going to talk about this tomorrow. Ministry of Health, Ministry of Education interactions. How do you make sure that you're training people appropriately for the jobs that the Ministry of Health have deemed need to be done? Right now, there's a huge disconnect in a lot of the countries that a lot of us work in, and that needs to be helped. And that's a potential interaction that can be improved. But one of the main things, and my organization does a lot of this, is continuing education. Ability for professionals, for practitioners to maintain their skills, maintain their knowledge, even advance their skills, advance their knowledge, change jobs, advance their careers, climb up the ladder, so to speak. There's no opportunities for that. There's very few opportunities for that. We run one of the only, actually the only continuing medical education course in Ghana. And that we're basically the only source for these folk to get their CME, which has been mandated by their governing bodies. So very frustrating for practitioners in countries where they don't have access to that kind of thing. A nice study was done showing, are there any correlates with people sticking around in the country in which they were trained? And yes, there were. There was a few. If there's a compulsory service program, surprisingly enough, they stick around. So Ethiopia, 99% of people do not flee the country as soon as they're finished grad school. And in Thailand also, they stick around. And the reason for that is that those institutions, those governments rather, the training is heavily subsidized. So they basically own you for a few years afterwards. In Thailand, I think it's 3. In Ethiopia, I think it's 4. But basically, it's kind of a, hey, we'll train you, now you owe us a few years. And hopefully within that time, it can seduce them to stick around longer. One of the other positive correlations was a moderate number of post-grad medical education courses. The ability for these dedicated professionals to maintain their skills, maintain their knowledge, improve, keep up with what's going on in their world. And then the last thing, for those fans of irony, is that if French was one of the languages of instruction, there seemed to be a greater retention of graduates. Personally, I think this is a confounder. I think the French government is very heavily invested in a lot of its ex-colonies, and I think that there's probably a correlation to do with that rather than the actual language in which they're taught. But I thought I had to write that section in French. So I wanted to talk about a couple of projects where I thought were really, really innovative, really creative, and really interesting. In the Philippines, they have what they call the stepladder program. Basically what they do is they take the village health worker. They give them a little more training. And at that point, they become, or they're qualified to become midwives, occupational therapists, pharmacists. At that point, they could say, hey, you know what, I'm happy to be a midwife, I'm going to go off and do that. Fantastic. If they want to continue on, after 15 months total, they become a licensed nurse. And if they're happy then, if they want to be a licensed nurse, fantastic. They jump off the train, so to speak, and they go and practice nursing. If not, if they have ambitions to become a physician, they stick around for 5 years, they become a physician. Now this program's been running for a few years. They've run 3,000 people through it. 70% of them jump off at the midwifery occupational therapy level. 25% become licensed nurses, and only 5% continue on to the physician end of the spectrum. But what they found was that their emigration rate through this program, people who then left the country, was less than 10%. The College of Medicine in Manila has an emigration rate of between 50 and 100%, depending on which year you look at. So giving people the opportunity to continue their training, to jump on and off of this stepladder whenever they want, seems to make people happier, more suited, I don't know, but somehow less likely to emigrate, and that's got to be a good thing. And of course, you're training all these mid-level people. Speaking of which, this is another one of my favorites. The FIFA model. You all know what FIFA is. It's the International Soccer Association. The F stands for soccer. The idea is that this is kind of a transfer fee philosophy. So graduates from the University of Ghana, let's say, and immediately flees to Manchester. I don't know why you do that. Manchester's a hole in the ground. But he flees to Manchester. Manchester, the people who employ him, the university, the hospital, whoever it is, the country, the high-income country, pays a transfer fee to the institution at which that guy was trained. That enables them to recoup their losses because that guy's now fled, perhaps even train another couple of people who may stick around because now they've got a little more money, they've got a little better training, they can do some more continuing education courses, they can address these problems that have been plaguing their institution. I quite like this idea. It's early stages, there's only a few places doing it, it's been very kind of informal, we don't really have any data on it, but I think this is kind of exciting. I think it's an interesting idea. Task shifting, you're all familiar with that concept. The idea being that 70% of the jobs done by very highly trained people like me can actually be broken down into many other little tasks and have people who are considerably less trained do those individual tasks. It's been estimated that that will save about a fifth of the cost because all those lots of different people can do lots of the same little jobs and they require a hell of a lot less training. So there's a few examples of this that I wanted to highlight because I thought this was a really cool idea. The Pakistani lady workers. These are community health workers who get about 15 months training, 3 months in the classroom, 12 months on the job. And they're basically community health workers who take care of relatively minor but very common problems in the communities in which they serve. Some very good evidence that they actually treat community-acquired pneumonia in kids better than the hospitals do. Fantastic idea, saves a lot of money. You can have a lot more of them for the same amount of money, same amount of training. In Malawi, they have a lot of clinical officers. You've heard about them from several of the speakers today. These are folk who do anywhere from 2 to 4 years training, and they can do anywhere from very minor procedures, very minor anesthetics, all the way up to fairly complex trauma, orthopedic, general surgery type things, depending on the level of their training. Great idea. It really is a kind of a flexible model. You can have exactly who you need, where you need it. And the other example, which I thought was kind of interesting, was in Ethiopia. They've actually allowed several private high schools to train nurses, to train pharmacists, to train tech-type people in hospitals from high school. So they'll be graduating 18-year-old kids who will be pharmacists, who will be kind of CNA-type folks, straight from high school, getting them young, getting them ingrained in the community, hitting them up early to sign on, if you will, when they're young and idealistic to help their communities. So thank you very much for your attention. And I wanted to close with this photograph, first because I think it's fantastic. I didn't take it, by the way. The guy who took its name is at the bottom there. Fantastic photograph. But I think it underlines something. These guys have been fishing this way for millennia. I would never have taught them to fish this way. I don't even know how it works. But if I went over and they said, hey, teach us how to fish, I'd have a rod and I'd have a net, and it wouldn't work. But they know how to fish. And they're coming up with ways, they're adapting ways, they're taking some of the stuff we have, taking some of the money we have because they need it, and they're morphing it to their use to make the best that they can of their situation. Thank you very much.